Okay, so this is the August 2025 MEC Minute, and our topic this month is really a question. Could this patient you have in front of you be having a stroke? So what are we going to talk about today? What are our objectives? We're going to talk a little about risk factors for stroke, probably get into stroke anatomy a little more than you might want to hear, but I think it's important to have some idea of the anatomy behind strokes and what you're going to see on assessment. We'll talk about stroke assessment because I think in looking at some of our run reports, there are some subtleties to some of our patients that had strokes that we just didn't pick up in the field. And I think with a little bit more time, a couple more questions, we may have discovered there was a potential problem with a stroke and the patient should have been treated as a stroke. We're going to talk somewhat about stroke mimics. None of these really should be some big surprises to you. And I also want to focus a little bit on posterior circulation events or posterior circulation strokes. These could be tricky. These are types of strokes that involve the back part of the brain, and ED providers, neurologists, and others can have a hard time identifying a posterior circulation stroke and initiating appropriate treatment. It can be extremely tough. I'm not saying that you have to identify them in the field, but I think you should have some knowledge about these posterior circulation events, and certain complaints, certain patient problems should at least bring the possibility up in your head. Um, One of the things we're not going to talk about in this conversation is current stroke care and destination decisions. That's a whole different conversation. I'm more interested in talking about an appropriate stroke assessment so that um, your differential, the things that you think about as possibilities for causing the patient's complaint, is expanded, and you have a better understanding of what strokes may present like and some of the subtleties to stroke identification. So, start with risk factors. So, this is something that patients can do to identify their own risk for potential strokes in the future. None of these things are foreign to you. We all know that hypertension, diabetes, obesity really predispose to multiple medical problems such as stroke, such as heart disease and heart attack. I think we are seeing a big number of people who have atrial fibrillation. If you look over the past couple decades, atrial fibrillation has increased in frequency of diagnosis, and atrial fibrillation can increase your risk of having stroke. With the atria sitting there and fibrillating and not contracting, you can develop blood clots that can then break free, go up to the brain and cause symptoms of stroke. That's why there's such aggressive treatment of atrial fibrillation with anticoagulants. So these are things that we all have to consider and you might think about. If you see a patient who has stroke-like symptoms, consider, do they have atrial fibrillation? Do they have a history of high blood pressure or diabetes? Other things that may predispose them for having stroke. So why are we focusing on stroke diagnosis? Because time is brain. Uh, we used to say time is muscle with heart attacks. We've taken that same model and moved it to stroke care. It's just that stroke care takes a little bit more time and it's not as always as straightforward as a STEMI with ST elevation on a 12 lead. So if just from a perspective of every delay in thrombolytic administration of 15 minutes robs the survivor of average month of healthy life and decreases the odds of good outcome by 10%. So every 15-minute delay results in decreased likelihood of good outcome. For every minute treatment delivers faster, we patients gain an average of 1.8 days of healthy life. That may not sound like a lot, but if you start adding the minutes together, it can be a lot of days. Every hour without treatment, the brain loses as many neurons as it does in 3.6 years of normal aging. So a couple hours after your stroke onset, you can basically age your brain by 7 to 10 years. 2 million brain cells die and 14 billion brain synapses are lost every minute during a stroke. And then about 7.4, 7.5 miles of myelinated fibers or nerve fibers die every minute during a stroke. So just to give you a perspective of some of the things that happen based on time. So when you talk about stroke care, really our goal is to save the penumbra. Well, what is the penumbra? Well, if you look at the brain and when you've had a stroke, there's a certain portion of the brain that is dead as a consequence of the stroke and is not going to survive. And no matter what we do, we're not going to fix that part. There's a lot of the brain, hopefully, that is normal and healthy, and then there's some brain between the normal brain and the core or dead area that is called the penumbra. Penumbra, that is brain tissue that may not be perfused as well as normal because of this stroke. But if we can open up the blood supply to that area, that tissue is salvageable. So we want to get blood flow back to the areas of the brain that is ischemic. When you remember that at least 70% of our strokes are ischemic in origin, that should tell you or give you a good idea that why we need to save this penumbra. We do have patients that will recover if we treat them well. If you have a patient with a big clot, the clot is extracted by the interventional radiologist. We have patients who have miraculous recoveries, and we are able to salvage a lot of this penumbra, and the patient has good neurological outcome. Just the anatomy. This is looking at the base of the brain. So from the bottom looking up, if you look at the base of the brain, we have four big arteries that go to the brain. The first is the carotids, green arrows on the left carotid. We have two big carotids. They're anterior. They're the front part. They're in your neck. That's what we can feel for the carotid pulse. We have two vertebral arteries that run up between the cervical bones of the cervical spine and go to the back part of the brain. When we talk about patients that have acute strokes where we can do interventional procedures, we're talking about clots that are either in the carotid artery or in the middle cerebral artery. That's where the interventionist can go and aspirate or extract clot. Anatomically, when we look at symptoms of stroke, we talk about the anterior circulation, so the front part of the brain, which is supplied principally by the carotid arteries, and then we have the posterior circulation, which is predominantly supplied by the vertebral arteries. We have the circle of Willis, which is in the middle of the brain, where all these four arteries are connected, so it pretty much assures blood supply through the brain. But when we talk about anterior, posterior, middle cerebral, carotid, and vertebral arteries, I just want to make sure you have some basic understanding of the anatomy. If you talk about actual supply of the areas, if you look at the brain looking at from the side versus the inside view, the anterior cerebral artery perfuses the yellow part, the middle cerebral artery is the pink or red part, and the posterior cerebral artery is the posterior part of the brain. The red part is the middle cerebral, and that red part has a lot to do with the motor and sensory function of our body. So left side of the brain provides right-sided motor and sensory perception and tells the right side of the body to move and vice versa. So if something happens on the left brain, it affects the right side of the body. If something happens on the right brain, it affects the left side of the body. The left brain is also responsible for speech. And one last thing is if you look at the posterior cerebral artery, it also perfuses that little cauliflower looking thing underneath the blue spot. That's your cerebellum. That is responsible for coordination and to some extent balance. So patients with posterior circulation events have trouble with could have trouble with coordination and balance and other symptoms that are not your typical weakness and numbness. If you look at it from the perspective of speech, Broca areas on the left side in the area of the middle cerebral artery perfusion, and it has to do with your ability to express yourself and talk. Wernicke's area has to do with your ability to understand speech. So depending on which one of these areas is affected by the stroke, patient may have trouble expressing themselves. So Broca area is affected but they understand what you're asking them. So if you ask them to move their arm, they'll do it. If you ask them what day it is, they have trouble communicating to you, and vice versa. And then if you look at the picture on the right, you can see the different areas. The green stripe in the front is the motor area. The pink stripe is the sensation area, so they're right next to each other. And just a little below and anterior to that is the Broca's area for speech. The yellow area in the back is the occipital lobe. That is primary visual perception. So the back of the brain is where you understand what your eyes are seeing, and that area is affected by posterior circulation. So posterior circulation events could involve visual changes, and that's why I've got that circle. So components of a neuroassessment. Um, and we're going to talk through this, and I'll give you some examples of some structured assessments that you may consider adding to your practice. So level of consciousness is an important component. If the patient's unconscious, then they really can't participate in anything else. But level of consciousness is important. How are they behaving? What is their cognition like? When you think about the motor function, can they move their arms and their legs? Do they have symmetrical face? Do they have weakness? And if they have weakness, how severe is it? We look at the eyes. Are the pupils equal? Are they up? Do they have trouble with their visual fields? In other words, if they're looking straight ahead, can they see central vision, but can they also see to the right and to the left? So is their peripheral vision okay? That can be affected at different points in the pathways of the visual nerves. And then what are their eye movements like? Because sometimes, depending on which part of the brain is affected, particularly the base of the brain, the eye movement may not be good. There's something about cranial nerves. We won't get a lot of that, but it has to do with facial symmetry. And then the sensation. Does the patient have normal sensation of the arms and the legs? And the reason I'm saying all this is, if we're going to treat for a patient for stroke, we first have to identify that there's changes present that are consistent with a stroke and maybe change how we're going to treat the patient, how we're going to notify the hospital, and maybe make a difference in terms of which hospital we transport the patient to. So signs of symptoms of neurologic decline, we think about headaches. Patients could have a hemorrhagic stroke with a severe headache. Nausea and vomiting is an important component, particularly in the posterior circulation. Is the patient having a decline in the level of consciousness? So sometimes with a stroke, particularly a hemorrhagic stroke, they can, excuse me, have change in their level of consciousness, and it can get worse. What is their speech like? Do they have facial droop? What are the pupils like? Do they have weakness or paralysis? Do they have a seizure? A seizure is one of those stroke mimics, as is migraines. So, is the patient having a typical migraine? We don't know. And are there any changes in the patient's vital signs? If the patient normally has a blood pressure, it's a little bit up, and now their pressure is very high, that may make it, may think more about, hey, this patient may have a head bleed rather than an ischemic stroke. But all these things are important. So, the neuro assessment talking awake alert orient times 4. I think that's a good place to start. I like the AVPU because the patient's awake and alert, or they're alert, they're sleepy, but they wake up to verbal, or they wake up to noxious or painful stimulus, or they're totally unresponsive. What I like about that is it's pretty easy to replicate between examiners. So it's very consistent. Whereas if you look at some of the other terms used for level of consciousness, some of this can be, confusing or different of opinion. Patients fully awake and alert, or they're in coma. That's pretty straightforward. Patients obtunded versus stuporous. To me, it's they're awake and alert, or they're unconscious, or they're sleepy or lethargic, but respond to verbal or respond to noxious. So I think that's important. When somebody's in full coma, it means the reticular activating system of the brain is damaged. It's the reticular activating system that keeps us awake and alert. And if that is damaged, we may not be, or we will not stay awake. Speech, it is important to get some idea of what their speech is like, and we've all had patients who have speech impediments or accents that may not seem normal to us, but is normal for the patient. But the speech patterns, is it thickened? Is it slurred? Is it understandable? The patient could have slurred speech, but I can understand it. Do they have aphasia? Do they have Broca's aphasia, where there's expressive? They understand what you're saying, but they can't talk with you. Or do they have Wernicke's, where they don't understand what you're saying, but they can talk clearly? Sometimes we have to discriminate between dysphagia, I'm sorry, aphasia, where a patient is having trouble speaking, with dysarthria, where it's not a trouble with finding or understanding words, it's trouble articulating. So they can't pronounce the words correctly. And that's a motor deficit. That's a speech problem and not a problem with aphasia, where the patient either can't express themselves or understand language. Echolalia is repetitive speech, repetitious speech. We'll see patients with that, and it can be sometimes due to stroke, can sometimes due to mental health issues or medication side effects. But it's something to identify if you see it. Talk about movement. Patient can move their arms or legs. If not to verbal, can they do it to verbal stimulation? For us, when we're assessing for stroke, do they have full strength, or do they have weakness? Can they move against resistance, or can they just move it on the bed, but they can't lift the arm up off the bed? So we can grade muscle strength based on how strong they are. Normal strength, no strength or no movement at all, and gradations in between. We typically say a grade 4 is they have strength against gravity, but it's not full strength. 3 is having trouble uh, with gravity, and 2 is they can move it around the bed. So, think about how you can grade the motor function, look to see how well they can move. And for most of our patients, they have 2 arms and 2 legs, so we can compare one arm to the other. And when we start seeing asymmetrical deficits, then we start thinking about stroke. Pupils, think about, are they equal or not? Most of the time for our stroke patients are going to be equal. If they're unconscious and you're starting to see an asymmetrical pupil, the pupils dilating, then we start thinking about, are they going to herniate? Look for nystagmus, which is those rapid beating movements. The patients can develop left to right nystagmus. We call that horizontal nystagmus, because of ear problems or because of brain issues. Sometimes patients have what we call congenital nystagmus, which means they have the abnormal eye movements as since birth, and it's for them it's normal. So think about nystagmus. If you see nystagmus that goes up and down or goes around in circles, that is bad, and that is not an ear problem. That's not a type of vertigo. That's really related to something within the brain. And then think about accommodations. If the patient looks far away, the pupils tend to get bigger. And if you move your finger in toward their nose, the pupils tend to get smaller as they focus. Vision is an important component of our stroke assessment. And when you have a patient with unusual symptoms, think about stroke or have unusual visual symptoms, think of it, could stroke be a possibility? So patients who have acute double vision without head trauma, patients who have acute blindness, or have what we call a visual field cut. So when we talk about visual fields, if you look straight ahead, so look at the color photo in the top right. If you look straight ahead, you're going to see central vision, which is both eyes working together. If you're looking straight ahead, but have something off to the right side, that's your right visual field, and anything to the left would be your left visual field. If you look at my arrows here, light coming in from the patient's right side is going to strike the left side of each eyeball, and that light is going to go by way of the nerves outlined in red to um, the left occipital cortex, which is the left visual cortex. So if patients are having left brain symptoms, they have a stroke in the left brain resulting in trouble speaking, right arm weakness, right leg drift weakness, and numbness on the right side. They may have a visual field cut as well, so they may lose vision in the right visual field. So it could be real quick. Can you see my fingers on the right? Can you see my fingers on the left? If it seems to be intact and equal, then they don't have a visual field cut. But consider adding this to your assessment of patients with potential strokes. If the patient's complaining of vision loss, we need to get an idea of, could it represent a stroke? If the patient acutely loses vision in one eye, so the whole eye is out, Then we think about, could they have something like a retinal problem, or could they have a stroke involving the optic nerve in the eyeball? They could have a small piece of blood clot or calcium go up into the retinal artery, and they can lose vision that way. But typically, if they're having a stroke, they're going to have a visual field cut. Think about drift. So, arm weakness. Um, Sometimes with excess patients, they seem to have good strength in each arm, have good strength in each leg. But if you test for drift, have them put their arms out, have them close their eyes, you may see drift, and the arm on the affected side will slowly drift down. They should be able to hold it up for 10 seconds without a problem. You can do the same thing with the legs, one leg at a time. Have them lift the leg about 6 inches up off the bed, have them close their eyes, keep it up, and if it stays up, they don't have drift. But if they're having problems, it may start drifting down. Typically, we give them 5 seconds on the legs to show drift. Well, why does this work? Well, if your eyes are open, there are ways you can accommodate if you see your arm starting to drift. If your eyes are closed, you will not know that your arm's drifting, and you cannot accommodate that, so the deficit can become more obvious. So think about testing for drift, both in the arms and the legs. It only takes a moment. And then look for facial symmetry. The seventh nerve is the facial nerve, and you're looking for symmetry. For stroke patients, you should see droop from the eye and down. Yeah, we'll talk about Bell's palsy in a minute. If the entire right side or entire left side of the face is affected, it's more likely to be a Bell's palsy. When we're talking about stroke patients, it tends to look for the corner of the mouth, look at the cheek. That's where you're going to see the deficit. Sensation, think about numbness to touch, and think about, does it match the motor deficit? If the patient's having right-sided weakness and left-sided numbness, that is very unusual, less likely to think about a stroke. However, if they have numbness and weakness is just on the same side, it goes along with having a stroke. One last thing, just about a way to check your patient. Sometimes if patients have posterior circulation strokes or strokes toward the base of the brain, they can actually affect how the tongue comes out. So have patients stick their tongue out. If the tongue is in the midline, that's fine. If the tongue deviates to the side of the stroke deficit, that goes along with the stroke. And once in a while you'll see this. It's quick, it's easy. You'll impress the receiving facility and the physicians if you tell them the patient has tongue deviation to the affected side. They would be surprised to hear that coming from an EMS provider. But I think it's a great thing to try. All right, let's talk a little bit more about posterior circulation strokes. So like I mentioned earlier, these patients can be very difficult to identify as stroke patients, and emergency physicians and neurologists and internists often have a hard time identifying these patients. The primary presentation is, I'm dizzy. Well, how many patients a day or in a week do you see that are weak and dizzy? We see a lot of them. And it can be one of the most difficult presentations to evaluate. So we have to ask the patient some additional questions other than, why are you dizzy or what does it feel like? And asking the patient to describe the dizziness is really not a great way to determine if it's a posterior circulation event or not. But we call it the 5 Ds of posterior stroke. So the back of the brain, um, and these patients can have dizziness and balance issues. They can have diplopia or double vision. They can have dysarthria. Again, dysarthria is trouble speaking. It's not trouble finding the words. They could have dysphagia or trouble trouble swallowing. So every stroke patient that comes into the hospital has a swallow screen before we give them anything by mouth. They can also have dyspraxia or limb ataxia, which means their coordination is off. So for a limb ataxia, you have the patient, put your finger in front of the patient, tell them to touch your finger with their index finger and then touch their nose, have them go back and forth a couple times. If they do it well, they're fine. But you may find that they can do it fine on one side, but not on the other. We call that limb ataxia. It's very quick. It's very easy. You can do the same thing with ask them to put their heel on one foot, from one foot onto the shin of the other leg, and just go down the shin to the ankle and back. If they can stay on the tibia, they're good. If they fall off either side, they're having problems. Getting back to dizziness and balance, these patients can have trouble sitting up, and if they sit up and get unsteady just with sitting, we call that truncal ataxia. If they can't sit up and maintain their balance sitting up, very good chance that they're having a posterior stroke. So think about that. Um, so these posterior stroke patients also can have motor and sensory deficits, can anterior mimic circulation. Think about posterior circulation events in patients who have headaches. Those patients can have a hemorrhage or bleed into the cerebellum. And those patients are absolutely miserable. They have headache, they can have severe intractable nausea and vomiting. They're dizzy, they're unsteady, and they simply cannot sit up in the bed. Those patients go right to CT. If cerebellar hemorrhages are considered neurosurgical emergencies, and often will go back to the OR with neurosurgery for decompression. The thing about posterior circulation events is CAT scans are not the great way to find them, particularly CAT scans without X-ray contrast dye. The back of the brain is not well visualized. So typically these patients will get CAT scans with contrast or CT angiogram, or the definitive procedure to rule out a posterior circulation event is an MRI. So dizziness, there's going to be a new little crib sheet, check sheet coming out from COTS for stroke patients. And we've added to the stroke assessment some dizziness questions. Is the room spinning or shaking? Was there a sudden onset, or is dizziness persistent within the last 6 hours? And the dizziness does not change with change in position. If patient says yes to all these, consider calling a stroke alert for a possible posterior circulation event. The hospitals have become very well attuned to early identifying these patients. As part of this conversation about posterior circulation strokes, I was trying to get a table or a chart that shows, how to discriminate between a patient who's weak and dizzy or has vertigo versus a patient who has a posterior stroke. There's no good chart I can show you regarding EMS. Many of the charts have to do with additional assessment tools, which we don't do in the field. So for you, it's going to be a high level suspicion. How does the patient look? How did it start? If the patient gets a little lightheaded when they stand up, that's not it. If the patient's had acute onset of spinning, dizziness, nausea, vomiting, and it's been ongoing, think about posterior circulation event. All right, some assessments. So, if you look at our process, we have a LAMP score in our protocol, and we use it principally to identify severity of the stroke and whether or not the patient may have large vessel occlusion and if they should be transported to a comprehensive stroke center. We don't have a lot of material in our protocol about how do you actually assess a potential stroke patient. So I've got two different tools you can use. This is BFAST. This is really promulgated among the public, um, so that they can identify a potential stroke and call 911. But I really like it because it really covers a lot of the bases for you as an EMS provider. What's the patient's balance? Have they lost coordination? If you do finger and nose, is that off? Do they have evidence of ataxia of their arms and legs? Are they unsteady if they try to walk? If they sit up, do they rock in the bed and fall back? What are their eyes? What's going on with their eyes? Have they changed in vision? Do they have double vision, loss of vision? Have they lost some of the visual fields? What is their face like? Do they have drooping features on one side or the other? I think that's pretty straightforward for us. Do you test the arms and legs for weakness in a limb? So this is a little bit more than the Cincinnati stroke scale. Do they have arm strength? If they hold the arm straight out, close their eyes, do they stay up? Do they have any drift of the arms or the legs? And what's the speech like? Do they have any trouble speaking or understanding others? For me, it's a good tool. And, yes, time, what's the time? Well, it's important for you as EMS providers to realize that time is important. When was the patient last normal? And, I need to get this patient to a hospital fast. Another tool I like is the race exam. This, like Lamb's, was set up principally to identify patients at risk to have a large vessel occlusion. But I like the items they have in the left column, very similar to BFAST. Does the patient have evidence of facial palsy? Have them show them their teeth. Is it symmetrical smile or not? What is their arm function? Put their arm out at 90 degrees and see what they can do. Can they keep it up for 10 seconds? Same thing with the legs. Lift the leg up, keep it up for 5 seconds. What is their vision and gaze like? Do they have any evidence of deviation of the eyes to one side or the other? So if the patient has an acute stroke, um, the patients tend to have the eye deviation toward the side that the strokes occurred on. So if they're having a left brain stroke, the eyes tend to deviate to the left brain, and you should see that. Um, Aphasia. If the patient has right-sided hemiparesis, the right side is weak or paralyzed, affects the left brain, that's the speech center, and ask the patient to do two things. Close your eyes and make a fist. Do they understand? And do they understand? Can they talk with you? And then if they have left sided weakness or right brain stroke, are they agnostic, meaning are they ignoring the left side? So if they can't move the left arm, show them the left arm and ask them what it is. If they can tell you it's their arm, that's good. If they don't know, if they can't recognize or don't even know it's there, then that would be considered agnosia, and that is a bad sign and goes along with uh, greater likelihood of having a large vessel occlusion. But these 6 questions are good ways of making a quick patient assessment of could this patient have a stroke going on. So if you look at what we've got in our protocol, which is going to be modified, if you go to our existing version of our stroke score in ResponseSoft, you're going to see this um, form on the left-hand side. So the left-hand side is what it looks like when you open it up. On the right-hand side, I completed it for a patient. But it's a neat way of getting an idea what's going on with the patient. For this to work, you have to start at the top and work your way down. You can't jump around between the different questions. So last well-known time and date. Do they have facial droop? Do they have arm drift? And what is their grip strength? Those are 3 questions out of Lamb's. And then stroke alert criteria for the receiving facilities. Do they have stroke scale deficits? Are they over age 18? Symptom durations less than 5 hours. Blood glucose between 60 and 400. And have they had any head trauma? On the right-hand side, I filled it out. The patient was last known August 25th at 11:15 a.m. He has facial droop. He's got arm drift, and he's got no grip in his hand. So he has a Lance score of 4. So at the top it says it's time to take the patient to comprehensive stroke center. You also identified that he's got stroke deficits. He's over 18. He's got symptoms less than 5 hours. His blood sugar's okay, and he's had no head trauma. So he's a stroke candidate to go to a comprehensive stroke center. So if you haven't looked at ResponseSoft, take a look at it. We may modify this. We may add a little bit more screening questions to this between now and next year's protocol. But I think it's a neat little tool, and it should make life easier for you. So before I finish up, I do want to talk a little bit about stroke mimics, things that could make you think that the patient has a stroke, but maybe they're not, things we need to exclude. Think about seizures. So patients can have seizures. They can have uh, neurological deficits after the seizure while they're postictal. And it may look like a stroke, or they could have a focal seizure and they may have stroke-like symptoms as part of the seizure. Migraine headaches, atypical migraines, can give you stroke-like symptoms. From my experience, it's probably the strongest stroke mimic out there that I've had to deal with, and it can be complex. And often we don't diagnose it as a typical migraine until after the workup is completed. Mass lesions, so brain lesions, brain tumors can cause stroke-like symptoms. The 4 H's, which I'll talk about in a moment on the next slide, and then Bell's palsy. Bell's palsy can be confused with a stroke. Bell's palsy is an impairment of the peripheral uh, facial nerve on one side of the head or the other. It is a motor neuron lesion, and it's secondary to inflammation of the nerve outside of the brain, and commonly caused by a virus, and we're seeing it more and more associated with Lyme disease. Um, and the reason how we can tell the difference is if you look at the top slide, um, the nerves to the face come for the lower face, mid to lower face, come from one side of the brain, whereas the forehead nerves come from both sides of the brain. So if you have a stroke within the brain, um, generally only the face from the eye and below is affected because the upper part or the forehead actually has nerves coming from both sides of the brain. Whereas if the nerve, the peripheral nerve outside the brain is affected, the entire side of the face is going to be affected and the entire face will droop. And you will see loss of forehead skin creases on that side. So if you have a patient who's got left facial droop around the mouth, but has skin creases on the forehead, it's probably a stroke. If you have a patient with left face droop and loss of skin creases on the forehead, it's probably Bell's palsy. When in doubt, call it a stroke. We'll figure it out at the hospital. The four H's of stroke mimics hypoxia, hypotension, hypoglycemia, and hypoventilation. That's why we do vital signs. That's why we check finger stick blood sugars. Uh, we often see patients who have stroke-like symptoms. We correct their hypoglycemia and they get better. So think about the four H's. Finally, some clues about your stroke alerts, things to think about. Um, Patients who have acute loss of consciousness or change in consciousness with or without neurological deficit. It could be a patient who just drops or was complaining of a headache and then dropped. Maybe it's a head bleed. Patients who are confused with incoherent speech or difficulty understanding speech. We are very sensitive to preserving speech. We will aggressively treat stroke patients whose principal problem is speech, even though they have minimal other symptoms. It's because we want to keep the patient's ability to communicate. So often, even if their only deficit is speech, we will give them thrombolytics, clot busters to try to get that impediment resolved. Think about strokes in patients with headache. Do they have a past history of migraines? Is this typical to previous, or is it different? If it's different, do they have any other symptoms such as weakness or speech difficulties? What's their blood pressure like? Are they having neck pain? Could they have a subarachnoid hemorrhage? So think about that. Think about unusual severe neck pain or facial pain without injury or trauma. Really didn't talk about that before, but patients could have vascular problems that could result in stroke-like symptoms and facial pain. Think about patients having strokes who have facial weakness, droop, or asymmetry, and have the patient smile. Sometimes patients can have chronic deficits from previous strokes. Best thing to do is ask family member, is this their usual smile? Think about patients who have developed acute clumsiness, difficulty walking or balance, particularly if it's acute and happened in the past few hours. If it's something that's progressively worsening over the past week, it's probably not it. And then think about stroke again with weakness, paralysis, sensory loss, and particularly if it's more one-sided body than the other. Visual changes, you have to think about stroke. And then sudden vertigo with double vision, vomiting, abnormal eye movements, trouble swallowing, trouble speaking. And when I say trouble speaking, I mean dysarthria, where they simply cannot pronounce the words. So, okay, you've got a patient, you've got to take them to the hospital. What kind of things do you need to do for the hospital in terms of your communications? Well, make your report short and to the point, but cover the bases. What are the neurodeficits you found? What are their vital signs like? What is their finger stick? What is their Lamb score, discriminator between large vessel versus not large vessel occlusion? Is the patient on anticoagulants, and when was their last dose? How about other medications? Sometimes we get a better idea of what's going on with the patient based on their medication list because we have no other information available. When were they last known well? And get the best time you can. Maybe they woke up this morning with right-sided paralysis. They went to bed at 10 o'clock just fine. They got up to go to the bathroom at 3 o'clock without a problem. But at 6 o'clock, they couldn't get out of bed. Well, their last known normal was 3 o'clock when they went to the bathroom. Sometimes family members can give you some idea of when their last normal as well. I talked to them at 3 o'clock yesterday. They were normal. I called them at 8 o'clock this morning. They were not. Is there any witness to the event, and how does the staff reach them if they need to call them? Uh, we more and more make phone calls to family members and other witnesses to get an idea of when things happened. What is the patient's baseline neurological and functional status prior to the event? If they've had a previous stroke, what are their symptoms like now compared to after they had their last stroke? And then was there any head trauma? Because if there's head trauma, we go down the trauma pathway. And sometimes it's just not clear. Did the patient have a stroke and fall down and hit their head? Or did they trip and fall and hit their head and had a head bleed? Sometimes we don't really know and we assume the worst, typically start as a trauma patient and move it up from there. So just in review, strokes may have atypical symptoms. Make sure you perform and document an adequate assessment. It's more than just the LAMS. Hopefully, you'll spend a couple more minutes identifying motor deficits, looking for visual field cuts, and so on. Please document it all so that it's in the record so we can review it. With dizzy patients, think about, is this a possible posterior stroke? Think of the stroke mimics and the four H's. We can correct the hypoxia, we can correct the hypoventilation, we can correct the hypoglycemia. If the patient's having a seizure, we can treat them with midazolam and the stroke symptoms resolve. And then please give a clear, concise report, including the best estimate of last normal when you hand the patient off to the receiving facility. So that's all I've got. Hopefully I've answered some of your questions. And hopefully we'll continue to revise our stroke tool within ResponseSoft. If you have any questions, please feel to reach out. Thank you.